Okay. Um, okay. We're going to talk about CPR, which is a fun topic. And it's going to be everything's going to be based off of the recover guidelines. And we'll talk about what that means. So, yeah. Could you? Oh, that's nice. Too much? That's nice. Cool. There we go. So in human medicine, when they do CPR on an arrest patient, they usually get a survival to discharge of 22%. And in veterinary medicine, it's like between 6 and 7%. And so some of the criticalists at Cornell like saw the difference and were wondering, well, why does human medicine have such a high survival to discharge rate compared to veterinary medicine? And out of that question became the recover guidelines. So the recover guidelines is just the title of the series of papers that they've published on how to improve the standardization of veterinary CPR, basically. And so it's a whole initiative. Like you can read all 7 parts of the recover guidelines. You can go get certified to do CPR by a recover certified instructor. And so you're like recover certified. And all of it is just an attempt to train more people in veterinary medicine so that our CPR is better and the hopes of getting our survival and discharge rate up higher. I think there's a lot of like idealism behind that in terms of getting our survival rate up to 22%, but we don't have to talk about that too much. So chat for another day. So the first part of CPR is being prepared for it and trying to prevent it. So the best arrest is the one that you've prevented. So in a patient that is like a brachycephalic. Pointing out that your slides aren't moving. Oh, they're not? Oh, sorry, guys. Oh, that's weird. Maybe that. Let's. That's weird. Yeah. Strange. Oh, there we go. Okay. Thanks. Survival discharge differences. Okay. So the best rest is one that you can prevent. So in a brachycephalic that's going under anesthesia, they can break down as you intubate them. So having atropine ready and preventing that from happening as soon as you identify it is better than trying to give it atropine after it's already flatlined. Or a hypoglycemic patient, catch him before his BG kills him. So it's all about monitoring and intervening early. And then, that's so weird. It's not changing on my screen. How do I change it over there? Sorry, guys. It's not changing. Oh, sorry. Trying to fix the. It's just not change on the. something so weird. Screen one. See, it doesn't change up there. Okay, this is better. All right. Okay. Back on track. So, preparedness, and then, or prevention, and then preparedness involves just the crash cart and training. So, the crash cart is like number one thing that needs to be organized to have an effective crash and CPR event with everyone involved. And I'll go into that a little bit more. And then hands-on training, like you technically should be trained how to do CPR every 6 months, because it's not like riding a bicycle. It's kind of technical, you forget it if you don't use it. And so it's really good to have refreshers, and it just keeps the team's efficacy at a much higher level than someone who's been trained once and never has been refreshed. And then after an event, you can have post-event debriefing. So like a lot of times when we do crashes, it's good to stick around and we can kind of talk about how it went well, what didn't go so well, what we could improve on, what we did really well on, because those takeaways are really good for the next crash, so that we can always improve on it. So then early recognition of an arrest involves just identifying a patient quickly. So if you find a patient lateral in the cage, the first thing is, okay, is it unconscious? And does it have an airway? Is it breathing? Is there a pulse? The reality is the longer you take to start CPR on a patient that you think is dead, the lower their rate of survival is. And so technically you shouldn't really spend more than 10 seconds trying to assess whether or not the patient is dead. 10 seconds even feels really long in the moment. And so the argument is it's much better to start CPR than delay it. So if you have a patient that you pull out of the cage that you think has died, don't spend 30 seconds or longer than 10 seconds trying to figure it out. Just start CPR, and in the midst of it, we'll figure out whether or not it's a true arrest or not. I have definitely done CPR on patients that were not dead, so don't be ashamed if you do it. So the crash cart, this is kind of like our crash cart. Organization is key. So every drawer consistently has to have the same items in the same location, always stocked, because that consistency allows us to be able to identify what we need quickly without having to shuffle through all the drawers. So the first drawer in ours is the endotracheal tubes, the laryngoscopes, and the ties. The second drawer is needles and drugs. And the third drawer is like tapping. So chest tap kits or pericardiocentesis, needles, those angiocasts. And the first part is just like familiarizing yourself with all the contents in there, so that you know if someone's like, get me an endotracheal tube, you know where to go, or get me the angiocast, you know where to go. And then the other thing is keeping it stocked. So after we do a crash, we have to go through the cart and make sure that everything's restocked. And Amy's going to kind of go through a protocol so that we have it set in stone on what our approach to keeping it a well-managed crash cart looks like. But it's going to involve keeping it stocked, taping it when it's stocked, and restocking it after a crash. So it's super important. So when you talk about CPR, there is a strict algorithm basically on what to do. So CPR can be broken down into basic life support and advanced life support. The first box at the top is the basic life support, or BLS. And it talks about what one cycle is, and one cycle is 2 minutes. And we'll go into all this in a lot more detail. And then the second box is advanced life support, which is once you get a catheter in and start giving drugs and whatnot. So anyone that's like dies on the side of the highway and some good Samaritan goes to do CPR, that's basic life support because they're just doing compressions and giving breaths. Once you get to the hospital, they put an IV, they give drugs, that's advanced life support. And this is the algorithm that you follow, and we'll go through each of these steps. So basic life support, like we talked about, is compressions, and the goal of the compressions is to restore blood flow, right? Because when you have an arrest, your heart stops, and so the compressions themselves pump blood throughout your body and allows you to deliver oxygen to the tissues and remove CO2 from the tissues as well. So it's chest compressions and then ventilation, so breathing either with the ambu bag or with our anesthesia machine. And then the venous access kind of becomes the transition. Compressions are interesting. There's like two theories behind them. It gets a little bit nerdy, but I think it's interesting if you understand things more based off physiology. So there's two theories behind compressions. The first is the cardiac pump theory, and it basically just means that the heart's the pump. So when you're doing compressions, you're doing, in this theory, you're doing compressions directly on the heart, which squish the ventricles, and that pressure in the heart then increases and pops open the valves and shoots blood out through the pulmonic artery, pulmonic valve, and the aorta. And then that allows the blood to then circulate, which with each compression. The thoracic recoil, so when you release on the compression, the recoil reestablishes kind of negative pressure, and that sucks blood into the ventricles again from the cava. So that allows blood to flow throughout. The other theory is the thoracic pump theory, which is just that the chest wall in and of itself is enough to generate negative pressures, positive pressures to push that blood along. It's just a different approach to understanding how the blood moves. And some argue based off of the position of the patient, where you're compressing it, you might be using a different theory. So how to perform CPR starts with identifying your arrest, which we talked about. Don't spend more than 10 seconds trying to decide if it's dead. Start compressions, intubate it, ventilate it, start monitoring, place IV catheters, and administer drugs. Okay. So your compressions, you start them immediately. So if you've identified an arrest, start compressions. That's the very first thing you do. The goal, again, is to eliminate CO2 from the peripheral tissues and to deliver oxygen to the tissues. The first tissue you're delivering blood to or oxygen to is the heart. And that's probably the most important organ, and then the brain. The depth when you do compressions, if you think about a dog in lateral, his chest is maybe this wide. You want to do the compression strong enough that you're dropping it by a half. So you're reducing the chest size in lateral by half. So it's a big compression. The other most important part of the compression is the release. So you want full elastic recoil of the chest, because when you recoil, that's when your heart gets perfused. So compressing shoots it out, and releasing allows myocardial perfusion. Do you have a question? It might a little, but the whole cage is still intact, so it should be okay. She asked if if you break ribs, if that can affect recoil. It's honestly kind of better if you're breaking ribs in a way, because then you know your compressions are probably strong enough. So it's not a worry if you break ribs. A lot of times you will, especially in older, crusty animals. So first, compress it by a half and release fully. Then give about 100 to 120 compressions per minute. Faster is not better, and slower is not better. That's the sweet spot. So you can do it to the song of Staying Alive. If you sing that in your head, staying alive, staying alive. That's usually the beat to 100 to 120 beats per minute. And you as the individual compressor will do that for 2 minutes straight. So once you start compressions, you do it for 2 minutes straight. It takes about a minute to establish myocardial blood flow. So any shorter period of time and then a break will make you have to kind of reset the whole process. So you should hopefully be able to do 2 minutes. So the main takeaway, do compressions for 2 minutes. That's one cycle. Compress the chest by half and do 100 to 120 beats per minute. There's different positions that you can do CPR in. The first important thing to know is the back should always be towards you. So wherever you're doing compressions, the back of the patient is always here. And that's just because it can slip away easier on the other if the sternum's towards you. So in a normal kind of like hound dog with like a more normal chest, you do chest compressions on the highest part of their chest. So kind of where the rib arches. In a keel-chested dog, like a greyhound, you can do it more over their chest, and that's just because your hands will over their heart, and that's just because your hands will naturally slide to their heart location. So in terms of difference in theories, in the A image, you're going to end up doing the thoracic pump theory, and in the B image, it's probably the cardiac pump theory, just for the nerds out there. In a bulldog, that's the only dog you'll ever do on their back, because they're so just anatomically crazy that the most effective compression you can do is with them just completely laying on their back. And I think some of you were around for that bulldog last week where we did it on the back, and it was really effective. In cats, they're so small that you can either do like cardiac massage, where you basically put your hand between their chest like this and just compress like this. I find that it is really exhausting on your hand to do that. Like your thumb will cramp up in 2 seconds. So I always do it like a normal dog, like in image B, because you just fatigue less, and I think you have better efficacy of your compressions. The technique for the individual doing the compressing is the most important thing, and they always say this even when you like learn human CPR, is you have to lock the elbows, and it is the most important thing. It's the only thing that's going to get you through 2 minutes of like physical exertion. So really lock your elbows, and you have to position your elbows like right over your shoulders like this, and lock, and then have them right over your shoulders. And when you bend down with your core, not with your arms going like this, because that's not going to work for 2 minutes. You have to go like this. That's the only way you get through it. So you have to engage your core. So you started ventilating. You started compressing. You called everyone over, help, I have a crash. Then the next thing the person has to do that's with you is intubate them so that they can ventilate the dog. So that's intubate the patient and attach it to an O2 source, like our anesthesia machine, so you can bag them, or to an ambu bag. The number of breaths per minute, so the amount of times you're squeezing the bag for them, it's 10 breaths per minute, which is 1 breath every 6 seconds. It is really easy when you're doing CPR to get really excited and breathe a lot for them, but that's really bad for their brain. So the important thing is to really keep an eye on the clock, because if you don't, you're going to hyperventilate them really kind of easily. So always watch the time. The other frustrating thing when you hyperventilate them is that they can when you're monitoring your CO2, and we'll talk about that later, it lowers the CO2. So you think that you're having less effective compressions when you're actually just hyperventilating the patient. So it's a really, really important thing for the entire code for us to be careful about how frequently we're breathing for them. Inspiratory time is 1 second and tidal volume is 10 mils per kg. It just means that when you give a breath, don't do it slowly and release. Do like really fast and release. So we've started compressions. We've started compressions and we intubated and started ventilating the patient. So now the next priority is putting monitoring on. So this is still all within the first cycle, right? Like we got this done pretty quickly. So get monitoring on. Number one is the ECG. And that's because in between cycles, so when we switch compressors, we're going to need to look at the ECG to be able to know what to do. So get the ECGs on and your end tidal, place your catheter, give drugs, consider defibrillating them if you need to. And we can talk about open chest CPR briefly, but that's all the components of advanced life support or ALS. So the two most important parts of monitoring in CPR is the ECG. And that's because it allows you to detect what rhythm the patient has in between cycles of compressions. So after 2 minutes, the ECG has to be up and running for us to look at the ECG in between switching compressors and allow us to call out the rhythm. So so stop. Yeah, that's good. And then the end tidal CO2 monitor is the other monitor, and that's also really important for it allows you to just continuously evaluate your patient. The end tidal CO2 monitor tells you how much CO2 is being released with each breath or getting ventilated out. And it first of all tells you how effective your compressions are, because if you're able to deliver with each compression really good blood flow, then the amount of CO2 that's going to return to the heart, diffuse into the lungs, and come out and read on your end tidal monitor is going to be much higher than someone who's doing crappy compressions. So it's a good measure of your efficacy of compressions. It's a good measure of whether or not you've had return of spontaneous circulation. So if you've been doing compressions for the first minute and the end tidal's been 15, then all of a sudden it shoots up to 40. You probably have return of spontaneous circulation, meaning your heart's beating again. So if that were to happen, you would finish out your cycle and then look at the ECG afterwards, and you probably have the patient back. Once the monitoring is attached, you place your catheter. And the reason that's like the catheter is kind of secondary if you're limited with hands is because drugs really are not the most important thing of your CPR. And it's not the first thing that needs to really go in. I mean, I guess you can kind of argue that, but your compressions are the most important thing. No. He's not going. No. Not for me.
So when you're using the capnograph, you want to see it jump up, meaning like if it's 15-20, you want to see it go to 45.
45's high, but yeah, you want, when you're using your end tidal, you want to see it increase. Yeah. And the other thing with the end tidal is it helps you know whether or not you've intubated the right tube. So your trachea, if you intubate the esophagus, you can still get a reading on the end tidal. It's going to be like 5 or 6, and that's just because there's CO2 in your stomach that's going to come out. So the stomach's not going to, the esophagus isn't going to read 0 on your end tidal. It's going to be low. the trachea is going to be higher, right? It's going to be like 10, 15, but it's a good way to maybe help you decide, am I in the esophagus or in the trachea? If you're in the esophagus, it's going to stay at 5 and just sit there no matter how aggressively you're doing compressions. If you're in the trachea, it might start at 5, but it's going to climb up to like 13, 14, 15 if you're doing effective compressions.
And if you're hyperventilating, then it might be down at 5, meaning you
Yeah.
even then it gets lower.
Yeah, exactly. So if you're hyperventilating, it's also going to reduce your CO2, which is what we talked about. So to get IV access, you can put in a peripheral line, peripheral catheter anywhere. It's best to just try everywhere. No matter how many hands you have, just have them try front leg, back leg. If you can't get it, just do a cut down. The dog is dead. You're not going to do it any harm by cutting its skin. So just get a blade, slice it open over the vein, tent the skin, stab it, and open it up so you can fully visualize the vein, and then try to put a catheter in when you can visualize the vein, because it's going to be a flat vein if the perfusion's poor or absent. You can do an IO catheter, but that very rarely happens in the code. You can also, for a cut down, you can do it in the neck, which is usually the most effective place because that's obviously the biggest vein. If you do a cut down in the rear limbs, it's just such a small vessel and it's so flat that a lot of times you can't actually get it even if you can see the vein. So ideally you do a cut down jug. So in between cycles, you basically started basic life support. You're doing compressions, you're ventilating. Then you've moved to advanced life support, where you have your ECG and your end tidal CO2 monitor hooked up. And you're now 2 minutes in and you're ready to switch compressors. So whoever is keeping track of time is going to say, okay, it's 2 minutes, switch compressors. So in the switch of the new person stepping up to do compressions and the other person stepping away, you look at the ECG monitor. It used to be that you listen to the heart, which is what always used to be done. The Recover guidelines actually don't tell you to physically listen to the heart with your stethoscope. Instead, look at the ECG monitor. If your ECG leads are not functioning, if they've flown off in the chaos of things, of course, you can listen with your stethoscope, but ideally just looking at the ECG monitor. And the whole point is so that you can evaluate the rhythm. So there are 4 types of rhythms you can have during a code. 2 of them are non-shockable rhythms, and 2 of them are shockable rhythms. So the first 2 are pulses like electrical activity, and the second is just asystole, flatlining. And then the 2 shockable rhythms are pulses ventricular tachycardia or ventricular fibrillation. And I'll show you the difference between those 2. Or you can see return of spontaneous circulation, which will be a hopefully normal sinus rhythm at like a rate above 100 with pulses. So looks like I might show you those. Here, I'll show them to you now. I should have put these earlier. So this is asystole. This is just flatlining. So when you switch compressors and you see this, you know the dog's not back. You give it drugs. And we'll talk about those drugs. Pulse with electrical activity is a little tricky to define. It's just a kind of random rhythm that can be organized, it can be unorganized, but it definitely doesn't have matching pulses. And usually the rate is like lower than 100. And it can kind of look like anything, and it can really fool you because you'll think that you have the patient back because you're like, oh, that's a complex, but it's not regular and there's no real organization to it. But that would, totally easily these rhythms would totally fool me during CPR. So if you see this, it's about the rate and it's about whether or not there's pulses to it. So if you're at all confused, you can listen or feel for pulses and look at your end tidal. And if all of that is like, I'm not really sure we have anything back, just give it atropine and continue compressions. So then these are the two shockable rhythms. Ventricular fibrillation just looks like fibbing lines, no real anything going on. And it's just that undulating wave. Pulseless ventricular tachycardia looks like this. It's just really bad VTach without pulses. And so anytime you see this rhythm or this rhythm, you'll say, okay, like start the next compressors, and then we have to defibrillate once the defibrillator is like ready to roll. And we'll talk about how to do that. So what drugs do you give, right? So the whole point of looking at the ECG and calling out the rhythm is so that you know, okay, do we have a heartbeat? What rhythm is it? Does it need drugs or does it need to be defibrillated? The majority of the times they just need drugs, and that's the first line of treatment is atropine. Atropine is a parasympatholytic. It's used for asystole and pulseless electrical activity. You can also give it with other two rhythms. And then epi is basically the point of epi is to constrict the peripheral blood vessels so that it shunts blood more towards from the periphery to the main part, and then to increase the heart rate. So first the atropine gets rid of all your like parasympathetic tone, and the epi kind of works off of that, stimulates the heart and shunts blood to the heart. And that's used arguably for every for asystole and pulseless electrical activity, and definitely the first round of CPR. But so how often do you give drugs, right? So you don't give it every 2 minutes, you give it every 4 minutes. So you switch out your compressors every 2, and on every 4th minute you give drugs. Technically, the recommendation is 3 to 5 minutes you give drugs, but for consistency and math and ease of organizing when you're giving drugs, just give it every 4 minutes, because then every other compressor you'll give drugs. So you can also give lidocaine. That's if your shocking doesn't help with the VTach. So you can give lidocaine, and that's an antiarrhythmic. And then definitely if it's a patient that was on any drugs that are reversible, reverse those drugs. So with naloxone to reverse opioids, flumazenil to reverse benzodiazepines, and then atipamezole is antecedent, so for dexdomitor. And then like what dose do you give is just based off of the chart. You don't have to memorize it. There is kind of an easy way to think about it though. So in a 20 kg dog, and it doesn't really match up perfectly with the chart, but in a 20 kg dog, they'll always get 0.2 mils of epi and 2 mils of atropine. In a 10 kg dog, it's 0.1 mils of epi and 1 mil of atropine. But you don't need to memorize it. Just look at the chart. It's hanging right above our crash or our stat triage table. And then on the chart, it also tells you what the reversal doses are for naloxone, flumazenil, and antecedent. And it also tells you your lidocaine dose. And then on the bottom, in the orange, it tells you the joules per kg for when you shock a patient, and we'll talk about that. So how do you give the drugs? So if you have an IV catheter in at the first 2-minute mark, then you can give it IV, and you can just give atropine and epinephrine right away. If you don't have an IV catheter, you can give it intratracheally. So what you do to administer the drugs intratracheally is you double the dose that you would have given IV. So if it's a 10 kg dog and you were going to give 0.1 mils of epi, you would give 0.2 mils of epi down the endotracheal tube. But it's not as simple as it sounds. You should technically get a red rubber and feed it down into the trachea, down the endotracheal tube, push the drugs down the red rubber, and then follow it with like a puff of air. Some people follow it with like a puff of sterile saline, or sorry, a little splash of sterile saline, so it actually goes down into the lungs. Because a lot of times I think we give drugs into the endotracheal tube and it just sits there along the tube and doesn't actually get down into the lungs where it gets absorbed. And then reattach and start ventilating again. So that's the drug chart. That's above our crash cart. And then again, just as a reminder, you have asystole, pulseless electrical activity, VFib, and VTAC. And in between switching compressors, you call out what the rhythm is. And then that should technically dictate whether you're, how things move from there. When you have a shockable rhythm, so VFib or VTAC, those require defibrillation. And how you go about that is it gets a little clumsy because, like we talked about before, the worst thing to do is interrupt CPR cycles. The only time that it's worth interrupting it for is to defibrillate. So what you do is at the 2-minute mark in between cycles, you change compressors, you evaluate the rhythm, and you see VFib. Then this next person, you call out VFib, it needs to be shocked. Then the next person comes, starts doing CPR while another person is setting up the defibrillator. And so the defibrillator needs to be set, that's this thing. So the defibrillator needs to be set to 2 to 4 joules per kg for a biphasic machine, which is this one. And so usually you start low. So in a 10 kg dog, you'd start at 20 joules, which you can set on the little knob there on the left. You see it goes 2, 3, 5, 7, 10, and then 20. So in a 10 kg dog, you would turn that dial all the way up to 20. And then you'd grab those 2 paddles on the left and right, those black things, and you would put a ton of lube on them and get ready. And then there's these 2 orange buttons that allow you to shock. What you do is the second compressor has been doing compressions, and you say, okay, disconnect the patient from O2 and put the patient on its back. Put the paddles up against its sternum right next to its heart. So one on the left, one on the right, and yell clear so that the whole table is clear of people physically touching the table. Because if they're touching the table, they're going to fly across. So once you yell clear, you squeeze the orange buttons and it shocks them. Then you flip the patient back lateral and restart compressions. Once the 2-minute cycle is over, you reevaluate the rhythm, see if your shocking has done anything. If it hasn't, you switch out compressors, start another cycle, and then dial up your joules. So if you were at 20, you go up to 30, and then do the whole thing again until you actually started making some progress. Usually it takes 2 or 3 times to shock them to get their rhythm back under control. But it is kind of fun, and sometimes it can be the start of like getting something back, because it is technically the heart is contracting especially if it's pulseless VTAC. Yeah, it beeps a little. It's not that alarming though. Yeah, and whoever wants to see how to use it can go through it because it's way easier to show you than to describe it based off of a picture. And then for open chest CPR,
If it's not at this point.
open chest CPR is always like a resident's dream. It's so much fun. There's actually a lot of indications for it, and we could probably do it every now and then if anyone wants to, and we get an owner to agree to it. But indications for open chest CPR are thoracic wall trauma, pleural effusion, pericardial effusion. If you're in surgery, because then if you're in the abdomen, you just cut through the diaphragm and do open chest CPR through the diaphragm. Large obese dogs technically should have open chest CPR because they're so big that you can't effectively do compressions because they're just so big. And then technically the recommendation is if you've had unsuccessful CPR for 3 to 5 minutes. Basically all you do is you cut open the chest in between like the 3rd and 4th rib, open up the pericardial sac and start massaging the heart like this. So you're just doing compressions directly on the heart. Eventually we'll probably have like an open chest CPR kit in our crash cart, but I think we're probably, we'll take one step at a time. Yeah, technically the recommendation is to, yeah.
Medicine seems very calm about that. Okay.
Yeah, just watch out for the nerves. Yeah, you would. So there's been an arrest. So you call for help, you scream for help, and you start compressions. Then you designate a leader, and just so that someone's calling the shots and telling everyone what to do and keeping things organized. You then have someone keeping track of time. This is arguably the most important role because they're dictating how things are moving. So they're keeping track of every 2 minutes and calling out switch compressors every 4 minutes, give drugs, and they're recording the drugs you're giving and the different treatments you're giving. And when kind of an important thing to remember as the record keeper or timekeeper is to give positive feedback to whoever's screaming out things. So if someone says give 2 mils of atropine, the timekeeper says got it, 2 mils of atropine. So positive feedback in all of this in these types of scenarios are super important because it allows you to know within your team that you've all understood each other, you're all on the same page, and things are moving smoothly. That also goes for whoever's giving the drugs, right? Like if the leader calls out, give 2 mils of atropine, whoever is drawing it up, say, drawing it up, giving 2 mils atropine, then the timekeeper can say, wrote it down, you know, something so that we all know we're all on the same page and that what was told to be given was actually given, you know, so it just finishes up the loop. So the other roles are, you know, leader, timekeeper, compressor, ventilator, who's watching the time, someone who's going to look at the ECG in between cycles, somebody who's just lending an extra hand, like putting in catheters or doing whatever, and what else is there? That's probably it. Yeah. So in between, so again, just to review, your compressions are 2 minutes per person. After 2 minutes, you switch compressors. Between the switch, you evaluate this ECG. You call out the ECG rhythm. You then start the next cycle of 2 minutes of compressions. You switch after 2 minutes, evaluate the ECG, and give drugs. You can do this for as long as you want. Questions, concerns? I used to, so I kind of switched it. Like no, and it's kind of like changed. She asked if you give Epi every round, and no, not really. Like I used to, and then it kind of grew out of favor, and I like went to recover training, and they recommended just doing it the first time and then seeing how things went. The same kind of goes for atropine. Like I don't know what, the heads of recover are actually doing, but there's no evidence in like the literature to suggest that giving atropine and epi every round helps. So, which is why I said that like compressions and ventilating them is more important than the drugs. Because we've even here gotten patients back without even getting drugs in them. So it's possible. And then if whoever wants to practice in the future or now, we can always practice. We have a CPR dummy or mannequin that allows you to practice doing compressions, and we can start doing some drills on just like getting the flow down and getting the timing right. Evaluating the rhythm is going to be tough on a fake scenario, but at least it gets you in the habit of looking at the ECG and practicing just to think about calling out the rhythm. It's not as intimidating as it sounds. Like you don't have to be like an ECG expert to know, but because usually it's just asystole or pulsatile electrical activity, and there's no difference between the two. All we need to know is whether or not the dog needs to be shocked or not. So you don't have to get fancy with your words. But if you see something that's shockable, which is usually pretty obvious, call it out so that we can give him what he needs. Cool.